Hi everyone, welcome to Central Jersey Family Health Consortium's webinar series on embracing physiologic birth. None of the planners or the speakers have anything to disclose. There is no commercial support for this webinar. The program has been awarded 1.5 nursing contact hours from Central Jersey Family Health Consortium. To receive a certificate, you must register, listen to the entire presentation, and complete an online evaluation. I would like to introduce the presenter for today, Dr. Judy Lothian. Dr. Lothian has been a maternal child nurse, childbirth educator, and an advocate for birthing women for over 4 decades. The focus of her practice has been childbirth education. She is the graduate chair and professor of nursing at Seton Hall University. She is currently the chair of the Certification Council for Lamaze International that is responsible for developing the international certification examination for Lamaze certified childbirth educators. She is also the associate editor for the Journal of Perinatal Education and writes a regular column for this journal. Her advocacy work includes national leadership positions in Lamaze International and national work with Childbirth Connection, the American College of Nurse Midwives, and the Coalition for Improving Maternity Services. Dr. Lothian is the co-author of the official Lamaze Guide, Giving Birth with Confidence. It is with great pleasure that I get to introduce Dr. Judy Lothian.
Okay. Thanks very much for the opportunity of presenting at this very important conference, Embracing Physiologic Birth. And this presentation actually sets the stage for the very interesting and important presentations that will follow. Physiologic birth is generally defined. There can be little differences depending on who's actually doing the definition, but the natural process of labor and birth, the unfolding of labor and birth as nature designed the process, and this last very, very important, labor that starts, progresses, and ends on its own. The norm, of course, you know, in the US and in New Jersey's no exception, birth is intervention intensive. The philosophy is we're always expecting trouble. There is tremendous fear related to safety and litigation. Obstetricians, unlike many other disciplines in medicine, base too often their decisions, their clinical decisions, on their fear of litigation rather than on best evidence. The fear of pain, the rising maternal deaths has become much, much more of an issue, and especially the issue of many of these deaths are preventable, if not most of them. And the now stable, but too high cesarean rates. So this is the context that we're dealing with. The Listening to Mothers 2013 survey, which is the last national survey that we have, just take a look at the percentages. 94% of women in 2006 had continuous electronic fetal monitoring, restrictions on eating, drinking, movement, very high epidural rates, and instrument delivery and episiotomy rate still much too high. The cesarean rate is still hovering around 31%, even 7 years later. The important references that I'm going to be noting are the Cochrane database of systematic reviews, the Journal of Perinatal Education, and I'm going to make special note of the special issue in spring 2019 that has really the updated references and discussion on the care practices that promote, protect, and support physiologic birth. And then ACOG's incredible 2019 paper on approaches to limit interventions during labor and birth, and the 2014 paper on safe prevention of the primary cesarean delivery. I wrote a column for the Journal of Perinatal Education when the 2019 paper came out, and I called it the winds of change. It actually is like a breath of fresh air to actually see ACOG coming down on the side of best evidence and caring very deeply, it appears, to change practice to reflect best evidence. So very important documents, easily accessible online. World Health Organization 2018 recommendations for intrapartum care for a positive childbirth experience. This is one of the first documents that actually talks about the importance of women's satisfaction with their birth experiences. And this is a major update from their 1996 document on, quote, normal birth. And then tremendous contribution to the literature, Sarah Buckley's 2015, The Hormonal Physiology of Childbearing. Although Sarah had actually published several articles before this came out, so that we've had the advantage of having a deeper understanding of the hormonal physiology of labor and birth, and even late pregnancy and into the postpartum. It's hard to believe that if we went back 20 years, we were talking about the physiology of birth being, of labor and birth actually being effacement and dilatation, and having no understanding of the incredible importance of the hormonal physiology. And we're going to spend a lot of time on that in this presentation. It's really going back to basics, and looking at what I think of as the extremely simple, but actually complex story of birth. So we're going to look at the hormonal orchestration, the role of pain in the physiologic process. Pain plays a very big role, the role of fear, and then very importantly, the care practices that promote physiologic birth and the care practices that interfere with the physiology of birth. And those actually reflect the high intervention that characterizes birth in New Jersey and in the United States. So hormonal physiology, the three big hormones, oxytocin, beta endorphins, and catecholamines, and they all play a vitally important role. So oxytocin, and this of course is endogenous oxytocin. In late pregnancy, the uterus becomes increasingly sensitive to oxytocin, and increasing levels of oxytocin result, as we know, in increasingly strong contractions and increasing pain levels. And this is actually new information, and I'm going to talk more about this new information in a bit, that touch and support actually increase endogenous oxytocin levels and ultimately decrease pain perception. We have known from our understanding of what helps women cope with strong contractions in labor, when all of the comfort measures, we've always said the touch and support makes a difference. But now we have a greater understanding of the mechanism is because of what happens with the oxytocin levels, and we'll talk more about that in a minute. Endorphins and endorphin receptor sites also gradually increase over pregnancy. And as exogenous oxytocin levels rise, and endogenous, that should be, rise, and mothers manage the increasingly painful contractions, endorphins are released. And endorphins, as we know, create a wonderful, intuitive, dreamlike state, and pain perception decreases. And of course, the classic example of this are runners getting their endorphin highs, and exercise in general can increase endorphin release. But interestingly, and I think we can't lose sight of this, is the loss of pain with the epidural decreases both endogenous and oxytocin and endorphin release. And the catecholamine levels increase at the end of pregnancy, readying the fetal lungs for breathing. And in labor, stress hormones are released if mother is fearful or does not feel safe or protected. And this is much the same as the rest of us in our everyday life, with stress hormones increase if we're fearful or don't feel safe or protected. In early labor, high levels of stress and fear can stop labor. And we know the typical example of this is a woman who's in good, solid, hard leg, advancing labor. Her contractions are becoming closer together and stronger. And she arrives and is admitted to the hospital, and everything slows down tremendously. And of course, this is probably almost related to the fact that she's in a strange environment, taken care of by strangers, and all of that. Interestingly, at the end of labor, there's a natural surge of catecholamines that facilitates the quick birth of a baby, even in a tired mother. And I love the analogy that Michelle Odant has used for decades, as comparing this to what happens in the wild. So mama lion goes into labor, and in early labor, she senses trouble. She senses she does not feel safe. She senses danger. And so labor shuts down until she can get to a place of safety. But at the end of labor, when this baby lion is ready to be born, if indeed she senses danger, there is nature's protective mechanism is to get those catecholamines surging so that the baby is quickly born, and then she can get herself and the baby to safety. So I think it's a really lovely analogy. Makes complete sense. The role of pain in labor and birth. My memories of being a young childbirth educator a million years ago is that we talked about pain is an unfortunate side effect of getting this big baby through a small space, the birth canal. And we worked very hard to learn and teach comfort measures to deal with the pain, but there was literally no understanding of the value, the importance of pain to the physiologic process of birth. So the first thing is it certainly provides the alarm that brings support, and we're going to talk in a little bit about the importance of support and social interaction early in labor. And then we know that as labor progresses, the importance of support and actually facilitating the process of labor and helping women cope. It provides a guide for finding comfort. And this is, if we think of the analogy of having a blister developing on your foot, and you're out for the day without the opportunity of kicking off your shoes and making your foot feel better. But imagine it that you're walking along and you begin to walk a little differently. You perhaps lift the back of your foot out of your shoe a little bit. You may walk on the side of your shoe. You may walk on tippy toe, but the pain actually directs you to finding comfort. And of course, as you become more comfortable, it's because the pain decreases a little bit. And this is what we find women who have freedom of movement doing in labor. They respond to actually what they feel. I'm going to skip down to the last one. Protects mother and baby, especially in second stage. If you think that women if they actually feel the pressure and pain as the baby moves down the birth canal and respond to that by movement, then actually there's a protection for the mother's birth canal and the baby as the mother responds to what she's actually feeling. If she feels nothing, that bit of protection leaves, is not possible. And then the overall big value of the role of pain, and it somewhat ties in with these other three, is that it actually promotes the physiologic process of labor by, my words, allowing the hormonal orchestra to keep playing. And I mentioned this before, when women have epidurals and the pain is taken away, that feedback loop up to the brain, whatever the complexity of that feedback loop, when the pain disappears, oxytocin stops being pushed out. And what we know about oxytocin is, or new information for me, new research, is that oxytocin just doesn't just affect the uterus, but it affects the mother's brain. And we're going to talk about that in just a minute. So at birth, there are high levels of oxytocin, endorphins, and catecholamines. Endorphins and catecholamines in the baby too. Mother is alert and interested. Baby is alert, eager, able to find the breast and self-attach. And the mother and baby are perfectly ready to meet. And there's also the issue of the very high levels of oxytocin are going to go a long way in preventing postpartum hemorrhage or excessive bleeding. This is the latest research. Actually, less than a month ago, this came out. Birth as a neuropsychosocial event, and it's an incredible study that integrated the findings of 2 systematic reviews: maternal plasma levels of oxytocin during physiologic childbirth. So we actually measure oxytocin levels in the mother, and then we look at what's going on. And then a meta-synthesis looking at qualitative, subjective, quote, subjective data related to women's experience of physiologic birth, and then the tying together of the 2 things. What's going on with oxytocin and how is it affecting women's subjective experiences? And there are about 8 authors in this paper. You may notice Ovnes Moberg and Ekstrom Bergstrom, who did some of the early work on the breast crawl after birth, and they've done a tremendous amount of work related to physiologic birth. And this is easily accessible online. If you just type in the title, it's on PLOS ONE, which is again, major contribution to the literature. So let's look at what they talk about. And again, this goes into more detail on what we've already talked about related to oxytocin. The levels are 3 to 4 times higher at birth than at the start of labor, which is amazing, the difference. And remember, oxytocin levels have increased late in pregnancy too. Oxytocin is released into the mother's brain during labor, and it actually induces pain relief, decreases fear and stress levels, and stimulates social interactive behavior. So the oxytocin is not just causing strong contractions, and I think this is really amazing. But if the pain or stress for this mother get too great, this positive effect disappears, and oxytocin levels decrease. And we've known that when mother is fearful or or very stressed, that oxytocin levels decrease. The key here, if we really look at if pain or stress is too great, this is when we have to think about what is it that's happening in the environment and what is it that's happening related to support that actually allows the mother to deal with and manage increasingly strong contractions so that the pain or stress does not get great enough that the positive effect of oxytocin disappears and oxytocin levels decrease. So, and this is also important information, that the support and touch can further activate the oxytocin system and decrease levels of fear, stress, and pain. So, again, what we've been doing and not understanding exactly the physiology, that support and touch makes a huge, huge difference. So the psychological experience, and again, this is the same study. In early labor, we see women describe the importance of social interaction, caring, and nest building. And as labor becomes more advanced, there's an inner focus and a need for support. We know this. And as labor becomes more intense, we see an altered state of consciousness. And again, a memory from way back in the early days of formal childbirth education. I can remember talking at length in class about when women started being really out of it, that what do we do to bring them back to the real world? We shouldn't have been trying to bring them back to the real world at all, because this altered state of consciousness is actually helping them to cope with the contractions. And then in pushing, women become more active. They come back to the world. And then we see these higher levels of fear and pain just before pushing. And again, like the animals in the wild, this may actually be important from a physiologic standpoint to that final, I have to get the baby out. And right after birth, joy and pride, feelings of being enveloped by baby and family, the importance of touch still, and peace. And then in postpartum, lower levels, we see lower levels of anxiety and higher levels of social interactive behavior. And this is again, the psychological experience of women who have experienced physiologic birth. Once we've interfered with this physiology, all bets are off. We can do what we can do to bring things back to more normal, but this is, again, women who have experienced physiologic birth. And ultimately, there is, for women who have experienced physiologic birth, a transformative personality change that actually facilitates attachment and mothering and is induced by oxytocin. So the oxytocin has played this role all the way through the labor, and then going into postpartum, it still is working its magic. So the findings of this incredible study is the neurobiological processes induced by the release of endogenous oxytocin influence maternal behavior and feelings in order to facilitate birth. And the psychological experience during birth may promote an optimal transition to motherhood. And the spontaneous altered state of consciousness that some women experience may indeed be a hallmark of physiologic birth. And again, very important from our standpoint of working with women, the data highlight the importance of support and touch to reduce labor and stress and fear and pain. And women and their partners can benefit from understanding this crucial role of that oxytocin plays in the psychological and neuroendocrinological endocrinological process of birth. I think we would do well to really emphasize this. And women would also benefit from knowing what interferes in powerful ways with oxytocin-driven physiologic birth, and we're going to talk about that too. So these are, I don't have pictures of early labor. Some of you may recognize this as Allison Walsh, who's a childbirth educator in New York City. She also has a house down on the shore, so she's a Jersey girl too. But this is re-entering. This is obviously a home birth. This is re-entering the world, and a intense effort. Allison was very tired before this, but intense effort, but also almost a look of fear on her face, which wasn't really there before. And then this is probably a minute and a half later. The birth joy and pride, just this ecstatic look on her face as she holds her baby. And then this social attachment phase, where the children are there and her husband, and Allison is still focused on her baby, but is bringing the rest of her social network in. And more social interactive behavior. This is probably 10 minutes, 15 minutes after the birth. That's me and the midwife and the children and Paul, her husband. And more socialization. I love that picture. So, and the culmination of physiologic birth is of course the baby at the breast. So if we step back and we think about what actually happens in physiologic birth, we need to really look at what it is that protects and supports this physiologic birth and then ultimately breastfeeding. And there are a number of care practices, and for a more detailed discussion with lots more references, you can go to the Journal of Perinatal Education, spring 2019, and also the World Health Organization document. There is very solid consensus for all of these care practices. And the first and most important probably is labor starts and continues on its own. The incredible importance of labor support, freedom of movement, no routine interventions. Doesn't mean there are going to be no interventions in labor and birth, but nothing done routinely. And then non-supine positions for birth and following the natural urge to push. This one especially flies in the face of what we see as standard practice, and no separation of mother and baby. So labor begins on its own. Labor starts on its own. The baby, and this is why it's important. The baby is ready, and actually, the more we know about this, the more convinced we are that the baby probably initiates labor. The cervix is soft and ripe. There are increasing levels of oxytocin, and even more importantly, the uterus has become increasingly sensitive to oxytocin, with many more receptor sites for the oxytocin. If we induce a woman too early, it's not surprising that the induction may not work because of the lack of receptor sites to the oxytocin. And I think of this as the hormonal orchestra has warmed up and is now ready to begin the performance. It's interesting actually or it's important actually to remember that the amount of time it takes an individual baby to be ready to be born varies tremendously, which is why we always said, even before we could actually pinpoint fertilization and identify using ultrasound, doing a better job at identifying due dates, there's still tremendous variation. The variation can be as long as 4 weeks, so that some babies are completely ready to be born at 38 weeks when we can pinpoint fertilization, and other babies are going to take 42. So let's keep that in mind. The ACOG indications for induction, and they haven't changed dramatically since 2009. Spontaneous rupture of the membranes without labor. They do not say how long you wait. This one is really a surprise to people. 42 completed weeks, not just up to 42 completed weeks, 294 days of gestation, hypertension, eclampsia, preeclampsia, health problems such as uncontrolled diabetes, chorioamnionitis, and intrauterine growth retardation are other issues with the baby, and abruptsia placenta. Interestingly, induction for post dates, ACOG in 2014, this is a dramatic sort of change of thinking. Induction of labor after 42 weeks and 0 days, and by 42 weeks and 6 days is recommended. So we're talking about really understanding that it's close to 42 completed weeks before ACOG is saying induce. They're also saying induction of labor between 41 weeks and 42 weeks, both in 0 days. It could be considered. It could be discussed with the mother. The Cochrane review in 2018 says that from the relatively poor data, they're unable to answer the question of whether to wait for labor to start or to induce. And their recommendation is to offer women the opportunity to make an informed choice of 41 or 42 completed weeks. And WHO recommends 41 completed weeks. So we are talking about labors going much longer than is typical certainly in New Jersey and New York. We have to look at the risks here. So the risk for early term babies, 37, 38 weeks, is 2/3 higher mortality rates than babies born 39 to 41 weeks, and that's CDC data from 2016. ACOG 2013, babies born at 37, 38 weeks have increased risk for respiratory distress, transient tachypnea. Let's go back. Oh, sorry. Ventilator use, pneumonia, and NICU admissions. Babies born late preterm, this is the 34 to 37 weekers, higher risk for respiratory morbidity, apnea, temperature instability, hypoglycemia, jaundice, feeding difficulties, and they're 3 times more likely to die in the first year. Again, that's CDC data, which is important. Routine induction at 39 weeks, and this has been in the news and has been worrying lots of us since the ARRIVE trial was published in 2008. And that trial actually had 2 groups, women who were induced at 39 weeks and women where there was expectant management, although some of those women with expectant management actually had to be induced later. And so the control and the experimental group were a little off. We could say it's a weakness of the study, but at any rate, there was a small reduction in cesareans in the women who were induced at 31 weeks versus expectant management. Interestingly, both groups had cesarean rates well before the national below the national average. And I think that's really incredible. It makes me wonder whether they just got superb evidence-based care when they were in labor. The induced group at 39 weeks, the cesarean rate was around a little bit less than 19%, and it was a little over 20% in the expectant management group, both remarkably low cesarean rates in the United States today. The ACOG response was it's reasonable for obstetric care providers to offer labor induction at 39 weeks to low-risk women with confirmed due dates. ACNM, not a surprise, reaffirmed its commitment to promoting physiologic birth, which is not inducing at 39 weeks. Other biggie, induction for macrosomia. ACOG has not changed this. 60% of women in the Listening to Mothers 2013 survey believed that macrosomia, being worried about a too big baby, was a valid reason for induction. But ACOG 2016, and they've been saying this for a long time, it is not an indication for induction of labor. Induction of labor does not improve maternal or fetal outcomes. So again, this is a very big reason we've been doing inductions. Induction and cesarean. We go back to the ARRIVE trial here. There was a small decrease in cesarean in the induced group, but it was a very, very small decrease. And this JBI systematic review, it came out of Denmark, a really large group of women, routine induction at 41 weeks, not 41 completed weeks, but 41 weeks and 0 days, increased risk for cesarean, and also increased the risk for labor dystocia, chorioamnionitis, and precipitate labor, uterine rupture, and low newborn pH. So we're seeing conflicting data on induction and cesarean in those 2 very large studies. Induction and cesarean with Listening to Mothers, again, this is really important, I think, to think about. First-time mothers with term birth who were not induced, there was a 5% cesarean rate. Is that amazing? A 5% cesarean rate if women went into labor at term on their own and were not induced. If they had an epidural, the rate increases to 20%. It's important information. First-time mothers with term birth and induction, a 19% cesarean rate. With an epidural, the rate increases to 31%, which is pretty much what our standard is. Not our standard, but our national rate. I think that's very interesting and important information. Continuous labor support. We don't need many slides on this because we have so much rich data supporting the value of labor support. Going back to Klaus and Kennel's work, and the research on doulas and outcomes with doula support. So there's a decreased fear and an increased feeling of safety, decreased requests for pain medication, fewer requests for epidurals, more positive reports of the birth experience, breastfed for longer duration, more likely to give birth vaginally, less likely cesarean or vacuum, and slightly shorter labors. And no matter where we look, there's consensus on this one, including the Cochrane's latest systematic review, 2017, World Health Organization, ACOG, and both ACOG's 2018 and 2014 reports. This is interesting. From whom did you receive support in labor? Doula 6%. I would bet that number has gone up significantly. Midwives 10%. That may have also gone up. Another family member or friend, partner or husband 77%. And nursing staff 46, doctor 31. It's Green and Hotel in 2019. This is the JPE updated article with updated references, and that's in the Journal of Perinatal Education special issue. Nurses provide minimal support, and we could have a whole conference on what influences that. And fathers may not be able to provide adequate support. I think we can probably do a better job preparing family members to provide support, but we're still left with the issue of it's a scary experience for them too, and they of course don't have the oxytocin release in their brains to calm them down the way the mother does. And I think it's important that family members know that doulas assist fathers. They assist family as well as the mothers. They're there for the family unit. And this one is just so interesting to me, that non-medical people provide more effective support. And this could simply be one, they know ultimately, even if they may know this woman better, but it also is that the non-medical people are there just for the support piece. They don't have a myriad of other jobs like checking IVs and fetal monitoring and the epidural and all of those things. Of course, if we get rid of some of these routine interventions, it wouldn't be quite as complex a job, and nurses would be able to do that. Okay, we're on to freedom of movement throughout labor, and this is another extremely valuable support for physiologic birth. Lots of studies going back a ways, and of course we're not going to have a trial that actually makes some women stay in bed and some women can move around a lot. So there's no really clinical trial related to comparing freedom of movement to restricted movement, but we do know that in nowhere have we seen any evidence that there is harm from freedom of movement, and we know that movement and upright position is associated with maternal comfort and satisfaction. That should be enough, but We do know that there's less use of pain medication if women have freedom of movement. There's less need for Pitocin. We know that some positions actually help rotate the baby. We know that contraction intensity and efficiency is greater in standing or side lying, and it should be encouraged, and that's even ACOG in 2019 and World Health Organization in 2018. I think it's just helpful to know what the oh, sorry. It's helpful to know what the experts say about these things, especially if we're thinking about changing policy in hospitals. So non-supine positions for birth, and then pushing in response to the urge to push, as opposed to being told by the nurses and the doctors to push and hold, breath hold. So benefits of the non-supine position: it enlarges pelvic diameters, reduces the length of second stage, reduces the need for episiotomy. There's a reduction in assisted deliveries, there's less severe pain, and there are fewer abnormal fetal heart rate patterns. You would think that would be enough to make everybody want to do it. So pushing. Second stage starts with spontaneous pushing, not full dilatation. It is not unusual that there is a time lag depending on how high or low the baby is in the pelvis. There should be no arbitrary time limits as long as mother and baby are doing well. And there's no evidence to support the value of directed pushing, especially in women without epidurals. Cochrane, ACOG, Gordon-Romano. So the guidelines for pushing, and this is supporting the physiology of the normal physiology of birth, encouraging spontaneous bearing down, discouraging prolonged breath holding, supporting rather than directing maternal efforts, and encouraging women to change positions frequently. Very different than what we typically see in US hospitals. So ACOG guidelines 2019, winds of change again, insufficient data to support encouraging women to engage in breath holding, and each woman should breathe as she wishes. Women should be offered a period of rest at the start of second stage, bearing down with the urge to push, and frequent position changes. So we have ACOG taking a quite strong stand, and a different stand than they had taken previously. And again, good news in support of supporting and protecting physiologic birth. And laboring down, especially for women who have had an epidural, waiting until the mother feels an urge to push. The delayed pushing is not associated with adverse outcomes. Obviously, second stage takes longer, but it's not associated with adverse outcomes. And delayed pushing is an effective strategy to reduce difficult deliveries. ACOG buys it. And finally, keeping mothers and babies together. Very, very important. And one of the things I think that we've made tremendous strides in accomplishing. Although back in 2013, again, this is 7 years, 60% kept their babies with them after the first hour. 58% had baby skin to skin when first held. But this is troublesome. More than half the babies were separated from their mothers initially, and 26% separated for routine care. And that's especially troublesome since routine care, unless there's an issue with the baby, is, and even sometimes when there's an issue with the baby, is best done skin to skin. Maternal benefits, and if we go back to the importance of touch and keeping oxytocin levels up, and what's actually going on in the mother's brain with high levels of oxytocin, that it enhances maternal confidence, improves breastfeeding outcomes, enhances attachment, decreases bleeding, and stimulates oxytocin and endorphin release that reinforce mothering feelings, keeping mother calm, and help keep her baby warm. All huge, huge benefits. It's a lovely picture. And the infant benefits, physiologic stability. I remember as a nursing student, and we were teaching this until fairly recently, that newborns have apneic periods and very irregular respirations. Actually, when we keep babies skin to skin, they don't. Babies are meant to be with their mothers, or somebody skin to skin. Reduce time to effective latch, increase breastfeeding duration, less crying. Big, 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 because crying, believe it or not, my grandmother would have disagreed with this one, but crying is not good for babies. It's not good for babies. They go through their brown fat really quickly. They become hypoglycemic, very bad. Decreased exposure to infection, and allows for frequent baby-led feeds. All very, very important benefits. So what have we've got? We've got let labor start on its own, freedom of movement, labor support, a less intrusive second stage where mothers call the shots related to pushing with an urge to push and not having, not being on the clock, and keeping mothers and babies together. But what makes physiologic birth more difficult, and intensive labor and birth? And we're going to look today just at a couple. Restrictions on eating and drinking, routine intravenous, continuous electronic fetal monitoring, and epidurals. So no routine interventions. Why no intravenous? Well, we've always said intravenous is there just in case things go south very quickly, but life-threatening emergencies are rare, and IVs can be started very quickly. IV fluids don't provide nutrition or energy. IVs restrict movement, and fluid overload, which is not unusual, contributes to engorgement and artificially high birth weights, which then sets the stage for being very worried about babies losing too much weight and the cascade of interventions that happen around that. Oh dear. Why eat and drink? To maintain energy levels, for comfort, avoiding fluid overload and fluid electrolyte imbalances, and general anesthesia is rarely used. Going way back, the restrictions on eating and drinking were very much tied into what if that everybody got some kind of anesthesia, and the airway in those days was not protected, believe it or not. So even if general anesthesia is used, the airway is always protected. So this aspiration, if you have something in your stomach, is not as big a deal as it was way back when for a period of time, aspiration pneumonia from aspirating under general anesthesia was a major cause of maternal mortality in the United States. So this is an old quote from a Jargon article in 1999, but I love it. The odds of dying of aspiration in labor are less than that of being struck by lightning twice in 1 year. Intravenous fluids. There's no evidence for the routine use of intravenous, and there appears to be risks associated with the practice. This is tying together what we've talked about, concern with the risk of hyperglycemia in the mother and hypoglycemia in the baby. And very important, Cochrane encourages women to eat and drink if they wish in labor. So what the experts recommend, and again, this can help us. Who recommends eating and drinking? in labor. ACNM recommends eating and drinking. Cochrane recommends eating and drinking to the mother's desires. And still, in spite of good evidence, the American Society of Anesthesiologists and ACOG recommend clear fluids. Electronic fetal monitoring. The routine use is related to an increase in cesarean and instrument delivery with no differences in outcomes for the baby. And this is after, I think we're up to well into the high 40s randomized control trials. I've said to nursing students and nurses, every time you put a woman on continuous electronic fetal monitoring, you've done nothing to protect the baby. This is a routine use, and you have increased this woman's risk of having a cesarean. It's kind of an overwhelming thought. It restricts movement and potentially interferes with optimal support, including limited access to comfort measures such as showers, and freedom of movement in general. And ACOG guidelines, and I think a lot of nurses and healthcare providers don't realize this, but obstetric practitioners may use intermediate auscultation rather than continuous EFM. That was 2014, and ACOG in 2019, as an even stronger statement, recommends intermittent auscultation rather than EFM for low risk women as the standard of care. A very powerful statement, and again, a sort of a change in thinking. And the WHO recommendation is, of course, for monitoring is intermittent auscultation. So it's contributed. This Sartwell 2012. This is in a legal journal, which is interesting. Identifies the contribution to the rise in cesarean, failed to reduce cerebral palsy, which is why it was introduced to begin with. And of course, most of you know that it was introduced with absolutely no evidence to support its use, has decreased women's satisfaction, and may be responsible for 70% of all claims concerning intrapartum care in relation to brain damage. And again, this was from a legal journal. EFM is it's really an ethical issue here when the data are so clear that it puts mothers at risk. Augmenting labor. The contractions are stronger, longer, and more painful. This is augmenting with Pitocin. It interferes with the release of endogenous oxytocin. No endorphin release, so mother misses this nature narcotic effect. We need an IV and continuous EFM. There are restrictions on movement and comfort, and more likely to need an epidural. And then we're left with speeding up labor physiologically. How do we support the physiology of labor if we really do want to speed labor up? Continuous one-to-one support, movement, privacy is a biggie, decreasing fear and increasing the sense of safety, touch, eating and drinking, use of tubs and showers. So getting rid of the medically stuff and allowing this woman to actually work with her body in labor is going to make all of the difference. Okay, we don't have to go through on epidurals, every single one of these randomized control trials. There are probably even more in the last year. There are more cesareans for fetal distress. Women are more likely to have intrapartum fever. And this, of course, begins the whole cascade of interventions related to the baby after the birth. Longer labors, including longer second stage, particularly in women having first babies. Higher rate of instrument vaginal delivery and a lower rate of spontaneous vaginal delivery. None of this is to say that sometimes an epidural actually is a good thing. but the effect on the physiology of birth is important. There's a cascade of interventions, including the need for some restriction on movement and probable need for Pitocin. And then there is, and this is the biggie, the disruption of hormonal orchestration of labor that ultimately slows labor, makes descent and rotation of the baby more difficult, increasing the number of malpresentations, and has the potential to affect postpartum bleeding and breastfeeding. So it's not a surprise that what we see when women get epidurals, and we talked about this earlier, is that oxytocin levels go down because the pain has disappeared. Natural oxytocin goes down, requiring Pitocin, and the muscles of the birth canal actually lose their firmness, and so it's much more difficult for the baby to actually rotate and descend than if that epidural was not in place. Epidurals and infant outcomes. The increased rate of sepsis workups during because of the maternal intrapartum fever, and that involves increasing some risk for the baby, separation of mother and baby, so therefore giving up all the wonderful advantages of mother and baby being together. There's an increase in hyperbilirubinemia. We don't know exactly why. And there's some evidence that state control is affected for the first days, maybe less alert and less mature in motor function for the first month. But there are mixed results in that study. But I'm remembering some of the early studies on keeping mother and baby together and allowing baby to crawl to the breast. And certainly the epidural babies had a much harder time, were very, very disorganized. And it took a while for them to be able to get it together to self-attach, to find the breast and self-attach. Epidurals make a small but significant contribution to problems establishing breastfeeding and shortening the duration of breastfeeding. And fentanyl appears to be the culprit. In this presentation, I didn't talk about opiates, but when we put an opiate in the epidural cocktail, then all the negatives related to opiates we have to actually consider. The notion, by the way, that I think all of you probably know this, the notion that anything in the epidural does not get to the baby is completely wrong. It gets to the baby in perhaps slightly lower concentrations, but it gets to the baby. So what do? How do we help women who when we're protecting, promoting, and supporting physiologic birth, is how do we deal with the pain without the epidural? And we know that's wide array of comfort measures, and we know so much more about what helps women find comfort or decrease pain, decrease the level of pain, or increase their ability to deal with the pain than we did 20 or 30 years ago. We've learned from the women who have actually, and we've learned from doulas, and we've learned from research. So there's a wide array of comfort measures, and unfortunately, we very often send women into hospitals where they have very limited access to these comfort measures, and sometimes to such an extent that the epidural is their only option for pain relief, and that's troublesome for sure. Support, movement, eating and drinking, and touch. All of the simple but magic solutions. If we had another half day, we could spend a lot more time on this, and I know some of the presentations that will follow will address some of these issues, but I think that childbirth education is extraordinarily important. Women and their families need to have a much deeper understanding of what physiologic birth is, why it is so important, why interrupting the physiologic process brings interrupting without medical indication, brings problems, increases risk. Childbirth education should also address, and I didn't in this presentation, is how to, if one does need an intervention, how to continue to keep as much as possible the physiologic process going. And of course, touch and support are going to play enormous roles here. Midwifery care is essential. If we think in terms of promoting, protecting, and supporting physiologic birth, the midwifery model of care is extremely important. The developing of relationships, the building of trust, the support, the commitment to only intervene if there's a clear indication for it, not depending on routine interventions like restrictions on movement, eating, drinking. That makes a huge difference related to promoting, protecting, and supporting physiologic birth. I think we need increased access to home birth and birthing center births and birthing centers. It is much easier to support physiologic birth outside the hospital at this point in time. Our great hope, and what all of us have worked for decades, is to actually have more home-like births in hospitals, and we can do that to some extent, but not completely. And doulas do an absolutely remarkable job. The notion of having a doula for every woman in labor is something I think that is important. Doulas, even if it's midwifery care, even if it's a home birth, whatever. My husband wanted me to share this little story, that one of our daughters went into labor when her husband was at work and I was at work and he was at home, and she left her teaching job and came with her dad for the first 3 or 4 hours of a very fast moving labor. And since then, he's referred to himself as a doulos. And he actually did a grand job, but it was probably because he spent so much time with me. At any rate, I think community-based projects are doing a phenomenal job at increasing women's confidence in their own ability to give birth, and providing support and encouragement and confidence in women. I mentioned Sisters in Birth, which is a project in Mississippi, and I know about it because there's an article in the upcoming issue of the Journal of Perinatal Education, which should be out in the middle of October. And the community birth workers in this project, by the way, it's run by an amazing woman, Getty Israel, but they have managed, in the first 55 women who have come through the program, they have reduced the cesarean rate to 24%, where in the state of Mississippi, it's hovering around 40%. They have increased breastfeeding to 88%, and in Mississippi, the percentages are dreadfully low. And they have decreased preterm births in a largely Black population to under 11%. And again, that's a dramatic difference in the Mississippi stats. It's an article worth looking at, and I know that we have similar projects in New Jersey and New York that are making a very big difference. And again, the overwhelming what we're seeing in these projects is building women's confidence that they can trust birth, that they can do it, and then having relationships and the really important support factor all the way through the pregnancy, the birth, and postpartum. So I think this has the potential to make a very big difference for us moving forward. And then there's the policy challenges. It's policy on a federal and a state level. It's also policy related to the individual institutions that we're working in. And just as again, this is a whole would be a whole presentation in itself. But I think what's really it's worth going to the Childbirth Connection website and looking at the blueprint for advancing high quality maternity care through physiologic childbearing that was published in 2018. It's open access. Go on and take a really good look at it there. It can provide some important guidance for those of you who are working in institutions and eager to make change. Yeah, I think we're at a very, very important point in time. The notion that we now have a tremendous amount of research that supports not just the value, but the importance, the critical importance of birth physiology. And we also have increasing evidence of the risk of interfering in that process for both mother and baby, both short and long term. And we finally have organizations that are important organizations like ACOG who are taking, whose guidelines are now reflecting this evidence that we have in support of physiologic birth and the risks of interfering with the process. So lots of work to do, but important work for mothers and babies. Anyway, I'm missing an audience, but I would love to hear questions, comments, thoughts. Feel free to contact me at my Seton Hall University email address or call me on my mobile. I may not pick up, but if you leave a message, I will get back to you. I promise that. And I look forward to having one-to-one chats with any of you who, and I mean that, who have, watched this presentation. And I also want to say thank you to Central New Jersey Family Health Consortium for its vitally important work for women and their families. And I want to thank all of you who are encouraging women and healthcare professionals to embrace physiologic birth. It's extremely important work.
Hello?
Can you hear me?
Yes, I can.
Okay, good. Okay, so I have the slide up.
Yep.
And you can start at any point that you want.
Okay, sounds good. Central Jersey Family Health Consortium would like to thank you for watching this webinar. Within the next 24 hours, you will receive an automated email from GoToWebinar. The email will include the link to the evaluation. If you would like to receive nursing continuing education credits for viewing this webinar, you must complete the evaluation. Once you've completed the evaluation, you will receive your certificate within about 2 weeks. Thank you for joining us.